Good afternoon. My name is Patricia Friesen. We have some people with us via webinar as well, so I know everyone knows me here. On behalf of the special week of activities that's called CREGÉS, and also on behalf of CREGÉS, and also on behalf of our CLSC Cavendish, I'd like to invite you and welcome you to this presentation. Our main speaker is Maryse Carignan, and she and I have known each other for a long time. We worked together in oncology at the Royal Victoria Hospital, but at this point she is a conseillère clinique, clinical advisor at the CISSS of Laval, member of the Commission sur les soins fin de vie du Québec, and she's also, for some years, has been the president of ACIO, the Quebec Oncology Nurses Association. And I would say she came up through the trenches as an oncology nurse at the Jewish General, so she's someone who knows our clients and also our the everyday oncology and problems of elderly as well. So a warm welcome to you, Maryse.
Thank you, Patricia. Now I have to sit so the camera can see me. Welcome, everyone. Good afternoon. I'd like to thank Patricia Friesen for such an introduction and for inviting me, and Patrick Durivage, that you probably all know as well, for the invitation. I've worked on the committee at the Ministère des Services de Soins et de Santé for the preparation of this tool that we're going to be presenting this afternoon. So I know it pretty well, but I've never worked with it like you maybe didn't work with it as well, because it's new. It came down in August from the Ministère, so everybody has to learn how to use it. It's been published a few years ago by Cancer Care Ontario, so some people knew about this tool, but officially, given the fact that since the law concerning the end of care life, there is an action plan that was made by the Ministère, and one of the action on that plan was to have an harmonized tool to identify people that would benefit from palliative care and end-of-life care and services. You probably know that some people are referred too late to palliative care team. Sometimes I know at my place, the nurse would say, I received this referral Friday afternoon, and when I called Monday morning, the person had died already. So we receive the consultation, the referral, much too late in the trajectory of the patient. And one of the objectives of the law is really for people to have access to palliative care and services the earliest as possible in the trajectory of their care. And this is a good practice too. It's not just the law, it's good practice that when we integrate palliative care and services way before in the trajectory of patients, not only we increase quality of life, but we also increase life per se. There is la durée de vie, the person live longer. So having said that, the tool as it is now is in 3 steps. Have you already seen it? Some of you, no? Okay. Some of you, okay. So the tool, it says here Cancer Care Ontario, but it's been developed by them a few years ago, as I said. But now it's really from the Canadian Partnership Against Cancer. And even though it's cancer, it's made for any maladie chronique. It's made for people with an incurable disease. It's made for fragility. So for, is that a fragility? Fragility, I mean, it's the term fragile patient. Don't hesitate to correct me. And the title is a little different. It's called A Palliative Care Approach for Primary Care. We changed the title in French. It's not going to be translated by the ministère, but primary care may have different connotation. Primary care here doesn't mean at home or in CLSCs. It means the first line of care. So how do we identify patient? En français, we called it l'approche palliative, quand et comment. Alors, when do we integrate palliative care approach and how do we integrate that? And this is what the tool will help us to do. I said there is 3 steps to the tool. The first is to identify our patients. We said it before, one of the difficulties is really to identify a patient. So how do we do that? With one simple question. Would you be surprised if this patient were to die in the next year? It's simple as enough as a question, but it's a very valid question. And it's a question that when you get an answer and you evaluate and you plan your care, it's very valuable to organize and the care of our patients. We also, to identify our patient, have some indicators of decline. I'll show it to them. I'll show them to you soon. And as the patient indicate a preference for palliative care. And when we ask the question, I will certainly not teach you anything. When we call about palliative care to some patients, they jump. I'm not going to die. Oh, am I dying? You're talking about palliative care. It's very misunderstood in the population what palliative care is. 30 years ago, maybe palliative care was a cancer patient who had 1-2 lines of treatment and nothing else could be offered and he would die in the next 3 months. Palliative care is not that anymore. We have technologies that make us give treatment for a long period of time. We have palliative treatment that lasts for long. Chronic disease have a longer survival with all the technologies we have. So palliative care is not a death sentence anymore. Yes, they have an incurable disease, and yes, they will eventually die. But it's not that it's going to be in the next few days. And it's not because you offer palliative care that you will not do anything. You will continue caring for the patient, but in a different way, with a different approach. You will look at pain management, symptom management, quality of life versus length of time. Okay? The second step is the evaluation. So we know the person will die in the next year. Assess this patient. What are the symptoms? You can use the Edmonton symptom scales for palliative care to assess symptoms of your patient. You can use any of other tools that you may have that is validated to look at the symptoms of your patient. But what are the symptoms? Pain, nausea, and you have a couple on the tool. Pain, nausea, depression, tiredness, lack of appetite, anxiety, drowsiness, shortness of breath, well-being. That's quite the symptoms that are associated with a decline. Performance status, you have scale to evaluate the performance status. You probably know the Karnofsky, the PPS, the Palliative Performance Scale that you may use in your practice maybe. If you don't, we'll look at it in a few minutes. This is a validated tool to evaluate the performance scales of your patient. The performance of your patient is not the only thing that you're gonna evaluate. With the symptoms, with the indicators, with the response to your question, and with the whole picture of your patient, you're gonna make a judgment about what is needed the most for this patient. But it's one valid tool. We'll have a look at the scale later on. And the third step is to plan and manage the care. We said in the first step that we ask the person what kind of care, does he accept palliative care or not? If he doesn't accept, why he doesn't accept, what does he understand of his situation? And that's very important in the evaluation, to see what the person understands and what the family understands. And that may evaluate also with time, with the change in the patient's position. And we're going to see later on a case study that will show what we mean by a change of condition over time. But you know that, I mean, you've seen it in your patients. We have to assess the understanding of the patient and what does he know, what he doesn't know. If you have seen the video in the session we have for palliative care, the video of a man who talks about his need when he was diagnosed with cancer, he talks about vocabulary that is used by professional care and how much the patient doesn't always understand. And sometimes you're going to talk to the doctor or you're going to talk to a professional and they're going to say, I told him that I cannot cure his disease. But depends on the situation, depend on the context, depend on the words you use. The patient didn't understand what you meant because we have our own vocabulary. So we have to make sure when we talk to the patient, to the family, that they understand what we meant. What it means, incurable disease, what does it mean? Terminal cardiac insufficiency, what does it mean? It's not always as clear as it is for us, for the patients. So the third step would be to plan and manage the symptoms, because we say that palliative care is mainly symptom management. So how do we manage symptoms? Is there medication that should be given? Is there other alternatives, medicine that could be given? How can we do that? And we also have different tools to manage those symptoms, to know how to manage those symptoms. I don't know how it's called in English, but le guide de l'ordre des pharmaciens sur les soins palliatifs qui donne tous les médicaments avec les indications, les symptômes, la façon de les administrer. You have website with Palliative that has also some tools. You have Cancer Care Ontario that has a lot of tools also that anybody can use on the website. So that's different tools that are available. We often say, oh, there are no services. Check first. Check in your community. I mean, you probably pretty know well the services that you offer, but sometimes the family do not know. So we have to inform them. We have to tell them. It's easy to say, oh, there are no services, but sometimes they are, and we don't know about them, especially the families. So it's important to tell them. And we'll plan care according to the PCS. So we'll do see that in details. Is that okay so far? Okay. So we talked about the step 1 to identify with the surprise question, with the indicators, and with the preference of the patient. We talked about the second step. How do we assess patients? We have some indication here with the score of the PPS about what does it mean. So the palliative performance scale will help us to answer some questions. Are the needs are met? Is there current resource at home? Is there more resources needed at home? How does the family cope? What is the distress of family members? How many family members is there to help the patients? You're probably all very familiar with that. I believe you all home care or CLSCs. What we say, the PPS is about 70, is that the person cannot no longer do his normal job or work, but they can still do some activities and some hobbies or housework activities. As the PPS decline, as the performance scale decline, the person does less and less. So is a few times a week a patient needs assistance with at least one of the transfer out of bed, wash, walk, toilet, eat. That's, we talk about a PPS around 60. 50 mainly sits on chair, lies in bed most of the time, needs help every day to do some activities. And PPS 40 and under, he mainly lies in bed most of the time. So that gives you a picture of your patient and helps you with your evaluation. And then plan and manage. So I've already mentioned some of those before because I wasn't following my diapo. I was talking free. So I think I've said most of that. But when we plan care, I talked about the symptom management, but when we plan care, we plan according to the score. And the score, what it will give you, or what we hope it's going to give you, is some facts to discuss the cases with the rest of your team, with the doctors, with the managers, to get more services. So when we talk about a PPS over 70, usually we can initiate advanced care planning because we know that une insuffisance cardiaque is not going to be curable. We know that a metastatic cancer is not going to be curable. We know that eventually fragility, dementia will evaluate and becomes an end-of-life care. So we can start while the patient is still in good condition, initiate advanced care planning. Below 60, we really initiate end-of-life care planning with patient. I don't remember SEM what it is in English, but bref. Symptom distress. Distress scale. It's probably the distress scale that we talked about in oncology that we have to fill for our patients. Under 50, initiate urgent assessment of understanding goals of care, especially relate to end-of-life care. Below 60, we're going to talk about referrals as well. And always remember, sometimes it's one point to explain also to the family. Sometimes they don't want the consult. Oh, it's not the time. It's not the time. But the thing is, when it's the time, you may have to wait for this referral or this consult. So it's always better to do it before than when it's urgent. Because Friday afternoon at 3:45, the phone may not answer where you call. So if you plan in advance, it's not going to make anybody die faster. It's just going to help us plan the thing. So when an emergency comes up, the family will be more prepared. And that's what we can use as arguments to make the family understand that even though we're not ready now, when we'll come ready, the consultation will have been done and the waiting time might be less. And again, the local resources that you have to consider. Because I don't know if it's the same here, but sometimes psychosocial resources, it's not because you ask a psychologist that you're going to have the psychologist the day after or the week after. Sometimes the waiting time is quite long. If you have medical equipment to order or may not be available at the time you ask for it. So if you do it in advance, it's going to be easier. And the resource, of course. And if that patient, when it comes below 60 or below, if that patient has not been referred to CLSC yet, it's time. He should be referred, and if the patient is home, of course, home care would be helpful also for that patient. It's okay so far? Okay. So that's what the algorithm look like between step 1, step 2, and step 3. That gives you a good idea of what we just been telling you. I told you that I would show you the scale if you've never used it. This is what the PPS look like, and the tool is 8.5 by 11, so it's easy to look at, to see what it looks like, and to read it, because it's big enough. What you may be less familiar with depends on the area you're working on. It's the ECOG. The PPS goes for palliative performance scales. The ECOG is Eastern Cooperative Oncology Group. It's a performance scale that we use a lot in oncology. So you may have some of your patients that come from an hematology oncology area or doctor that will use ECOG as a performance scales. So they did the scale here with the two side by side, so you can make the evaluation between the 0 ECOG with the 100% Karnofsky, because they go differently. The Karnofsky, the better you are, the higher rate you have. With the ECOG, it's the opposite. 0 means the best, and 5 means you're dead, and the Karnofsky is 100, you're at your best, and 0% you're dead. So it's just a difference. But you can see the balance here between the two scales, but they basically evaluate the same thing: the activity of the person, what they can do according to the evidence of disease, the self-care that the person is capable of doing, the intake, if the person is still eating, how much he's eating, and the conscious level. And they tell you completely at the left, you can see that over 70, it's a stable phase. But it doesn't mean that you can stop and introducing some concept of palliative care. Transitional phase between 30 and 70, sometimes it goes slow. Between 70 and 30, sometimes it goes very fast. And below 30, it's not for us. Below 30, that's really going down, and sometimes it can go fast. Depends on the situation, depends on the condition, the comorbidities of the patient. That can go fast. But you can never predict. You can never know. Sometimes we say, oh, it's a prognostic of three months, and they last for 6 months, or they go with 2 weeks. Usually it's shorter. The prognostic usually it's much long. It's evaluated much longer than it really is. But how am I doing in time?
It's 3:30.
Okay, I'm pretty good. Okay. I told you before that we have some indicators in the tool, so here they are. So you have some general indicators of decline that are good for everybody. So someone who's decreasing activities, comorbidity, general physical decline, and increasing need. Those are good for everyone, and you have some of them in the palliative performance scale as well. But you do also have indicators for specific disease, such as cancer. such as chronic lung disease, heart disease, chronic kidney disease, liver disease. So when you look at different disease, you may look at some of the indicators that may tells you that your patient is going towards end of life because the presence of those symptoms. If you have comorbidities and many disease, you take the one that at the moment is the most problematic for the patient. Or you can look at the tree. Let's say there's tree disease, you can look at the tree and make a hole out of it. But if it's, for instance, if it's a chronic lung disease that make much problem at this point, you can go with the indicators of the chronic lung disease. The neurological disease, so you have the main disease that we see, and frailty. Frailty. I was saying fragility before. Frailty and dementia, that you have also some indicators. Those are probably the ones that you see the most, but that gives you an idea of where your patient is at. Often we don't know when we deal with geriatric patients, are they normally going down, or is it a decline that goes to an end of life situation? It's not always easy to make the difference. So some people with experience may have facilities, but those indicators will certainly help the less experienced to make their evaluation. And the step 3, plan and manage. So what are the symptoms? Again, what is the care plan? What are the resources available? Is the patient as a comprehension of what is going on, and how we can make a whole of those 3 steps to really have a good idea of the situation of your patient and what services we have to make in place in order to help that patient. So we have a case study. Advanced care planning. Most of you know what it is, probably, but we have in Québec now des directives médicales anticipées qui ressemblent un peu à ce que pourrait être l'Advanced Care Planning. L'Advanced Care Planning peut être plus large que les directives médicales anticipées, mais cette nouvelle, this new aspect with the law help us to do active care planning, advanced care planning with what the patient would like and wants in terms of end of life. This is all the step that we have in the tool to help us to plan the care. The consult and the referrals, don't remember if I mentioned it in the previous hour or now. We talked about the referral to make them in advance, to make sure that we have them when we need it. But also, I want to say, some people wonder, when do I make a consult to the palliative care service? And of course, it depends on the criteria. Each palliative care service has its own criteria. Often is the prognostic that direct the direction to the palliative care service or not. But it's not always the case. The 3 months is really an administrative point for admission to a unit, for instance. Some dedicated team work with that 3 months, but less and less, I would think. And to say that our patient is eligible for palliative care, or to say that we start a palliative care approach with our patient, we don't need a prognostic. We just need all the items that we talked about before in the three steps of the evaluation. And palliative care team might be there as a consult team. They may be at the end of the line to answer a question, to inform you of what medication could be helpful, what intervention could be helpful for this patient, for this situation. They don't have to take care of the patient. They may just, as the words say, be in consultation. So the case study was prepared by Patricia. I'll let her read it, and we'll see from this case study how we can use the tool. So she has to sit, otherwise we won't see her. Les chaises musicales.
Tous les deux, les musiciens. So this is a very loosely disguised patient that many of us know.
The name is real.
But the names have been changed and some details to preserve anonymity. So Mr. C is an 87-year-old man living with 24/7 private caregivers. His only daughter visits or calls daily. His caregivers are friendly and attentive. But since the death of his wife 3 years ago, he has spoken less, lost weight, has resisted going out of the apartment to attend family events and even to medical appointments. Diagnosed with dementia 8 years ago, he also has a history of COPD, type 2 diabetes, chronic renal disease. He has an indwelling Foley catheter for the last 12 years subsequent to prostate surgery. The CLSC nurse was visiting every 2 months previously to monitor COPD and his general health. This last summer, Mr. C would walk to the kitchen for meals, cooperate with hygiene care, but spend most of his day snoozing in front of the TV. He refused and stopped going to the Alzheimer's Day program earlier in the year. In September, his daughter sent him to hospital as he was agitated and had a fever. He was treated with septicemia due to a UTI. He remained there for 2 weeks. Not surprisingly, by 1 week of being in hospital, he was already unable to walk. His daughter, an endocrinologist in the same hospital, did not agree to a DNR, insisting instead that a level of care be C, so that there would be an option open to treat any subsequent infection. Eventually, she brought her father home to the caregivers he had known for years. The day after Mr. C's discharge, the CLSC nurse visited and noted that his speech was mumbling and unclear. However, respiration, his chest was clear. He appeared comfortable, was not moaning, was able to drink small amounts of thickened fluid. He's incontinent of stool, and has the Foley catheter had been removed during the hospitalization. I'm going to leave it to Maryse to take it from here with you. Do you recognize him? Some of you.
So if you were in front of Mr. C, if we go back to the tool, would you see a utility? Would you see a use for that tool in order to plan the care for Mr. C? How would you start? So the step one is the surprise question. Would you be surprised if the patient were to die in the next year? Is that something that, would you be surprised if Mr. C would be? So if we are not surprised. If you were not surprised, then you're gonna assess. So you're gonna assess the symptoms of Mr. C. So we know he had infection. We know he had lost weight. We know he doesn't do much of his activities since his hospitalization is mainly in bed. He's confused, I think you said, Patricia. I'm trying to remember. Alzheimer 8 years ago. Um, so he has a lot of symptoms, Mr. C, and he has a lot of many conditions that makes you think that he's gonna die. And the performance status of Mr. C, if we use the scale, how would you identify, how would you score the performance of Mr. C? He's mainly in bed. I didn't hear. 40%? Is he totally in bed or is he mainly in bed? Whatever. He's about 42 and 30 at this point in time. Would you say that Mr. C, if we look to our assessment and to the comprehension, would you see that Mr. C is in condition to understand this situation? So who would you deal with then? Okay, is the daughter comprehend the the daughter doesn't want to accept the situation of her father. Is this a case that you see often? So we have to help the daughter to become to a point that she'll understand that there is nothing more to the father, and some intervention are less beneficial or more detrimental to the patient, will cause more harm than good to his father. Like just before we said, if he's hospitalized again, his situation will decline again. So maybe it's not the best for him. So she will also evaluate in this situation. What we said also before is it's not, is she an endocrinologist in English? Yes. We can't assume because she's a healthcare professional that she understands everything, because the emotions are taking too many places, in too much space in the situation. So sometimes as professional, we go into that pitfall of, oh, she's a healthcare professional, she understands. No, she's the daughter. She has her emotions and she doesn't want her father to die. Especially doctors, they want to cure, they want to save. So it's even more when it's your own father. So just be careful not to fall in that pitfall. So with the scale, we can see that the PPS is low. We can see that the comprehension is not there because of the emotion, because of she doesn't want to. So we will have a work to do to make the daughter become to a point where she accepts, or she can deal with the fact that her father will be dying no matter what she does, and less intervention would probably help the quality of life of her father. With the general indicators of decline, we can also see that he's decreasing activities, he has few abilities, his general physical decline, he needs support. Reason shows no further active treatment. We've seen it before. Shows no further active treatment. We've seen it before that he stopped going to his activities, and he has a progressive weight loss. So he has anyway enough indicators there that things are not doing well. cancer is not his problem, but he has chronic lung disease. So does he have indicators in there that show some point of decline? When we have comorbidities, what we can do with the tool is take the ones that has the most problems at the point of, or we look at the different pathologies and we make a whole out of it. You can do either or. Sometimes you have enough just to look at the disease and say that it's enough, he's really in decline. Sometimes you have to make a judgment with the different decline, the different indicators according to the disease. Am I still okay on time? The neurological disease, it's not really our point, but we have some dementia due to Alzheimer, and we have some frailty because it's a geriatric patient. So that will give us also, you see in the dementia, we have the weight loss, the reduced oral intake, no consistently meaningful conversation. We may have that with, we have the incontinence that Patricia mentioned, and in the frailty, but you have the comorbidities, we have the weakness, he works less and less. Matter of fact, he doesn't work anymore because he's bedridden. So he has a lot of indicators. So the tool, that's how you can use the tool with the case you have. And because we don't know it yet, it may sound like it's going to take a long time, but as you will, because it's all things that you know already. So you're going to develop an easiness to use it, I'm pretty sure. So that's, oui, Patricia? I'm asked if we use that tool for family members. I think it can be used with family members to have an idea of how they situate their loved one. How sometimes we are surprised to see what the patient is telling us, what the family members are telling us. Sometimes the family members are much more adequate or realistic than the patient. Sometimes it's the opposite, but that may give us a good indication of who needs more help between the patient and the family members. So I would say yes, you can use it for family members as well, with family members as well. But if the patient is apt, of course, if the patient can take his own decision, of course, you use it for with the patients. But using it with the family members can give you an idea of the gap between the two. Is there a question? Oh, 10 minutes, okay. Is there a question in the far away, in the universe?
Far away is very good.
Is there any question here? Comments? Do you think it's going to be useful? Do you see a use in your practice for such a tool?
A guide. A guide.
It's a guide. And that's really what it is, because nothing will overgo the judgment of the professional, your own evaluation, the experience, the sensitivity that you may have in your work. But it's a guide. It's an help for the ones that have less experience, maybe for the ones who are beginning to work in this field. But as I see it, it also gives us some facts and vocabulary to be able to go with the doctor, or with, especially if the doctor doesn't believe too much in approach palliative or palliative care, or to go with your managers and see, here is a case, here is what is the decline, here is the indicators that we've seen, to try and get care and services for that patient. And over time, maybe increase the services. I'm dreaming, but it's permitted. No more questions? I was so clear, or nobody understood anything? Here is a question.
How, à partir du rivage, how about patient or family members who ask for palliative care approach in order to get more home care services?
Ah.
How can the tool help?
Okay. The question was how can we use this tool to get more palliative care services? I'm not a manager. I'm not holding the budgets, but I think that given the fact that those points are really good practices that are really based on résultats probants, really based on good practices, that gives us clinicians some words, some real facts to go to the managers and to the administration to try and change things. The tool is not made first, its first objective is not to get more services. We have to understand that. And the family cannot use that to increase the services. It's made to identify our patient and try to manage what the patient is needed according to the resources we have. Beside that, we can try and use them, but don't use it with the patient to get more services. I don't think that, to my point of view, it will not be ethical to do that. But it's for you, when you're back in the office, to go and see the manager and try to make some changes with the directors. Because the service would be organized with the resources we have, that we can change. It gives a language, it gives words, and everybody will talk the same language. So when you'll see that you have a patient with a PPS of 30%, everybody knows what you're talking about. Everybody will see what you have in mind. If you talk about the indicators, if you talk with indicators, and those are words that has a weight with the administration. Indicators. So that gives us some. Okay. Any more questions? Any more comments? You want to take my place? Well, thank you very much for your attention.